Achilles tendon rupture. The Achilles tendon rupture happens while doing sports activities, but especially the weekend warriors. But a predilection for it happening in patients taking fluoroquinolones and steroids is common. There will be asymmetry of the resting position of the foot, and clinical examination will confirm by a Thompson test or a Simon test to confirm the angle of dangle and no movement at palpation of the gastrocnemius compared to the opposite side. There will be swelling on the posterior aspect of the heel, and there will be history of injury. Rupture happens 2 to 6 centimeters above the calcaneal incision, which is a watershed area and a hypovascular zone. Regarding the treatment, nowadays we follow the Northampton protocol. We brace the patient for 2 months. We give the heel functional brace with 3 to 4 wedges, and these wedges are reduced after 2 weeks time. We advise the patient to have early protected weight bearing for 2 weeks. We prescribe VT prophylaxis for the patient, counsel the patient, and give a performa as well. We can also at outpatient clinic advise an ultrasound to confirm the tendon gap. Increasing tendon gap will reduce the chances of getting optimal results. A tendon gap of more than 5 mm is physically demanding individual, and tendon gap of more than 10 millimeter for those in low physical demand individual causes lower patient reported outcomes. Operative indications can be operative repair has reduced risk of re-rupture compared to the conservative management, that is 3 to 13%, 3 versus 13%. The infection rate is more in the posterior in the operative group, and the nerve injury is more in the operative group. Functional brace seems to have meta-analysis in 2012 has shown that the functional brace is almost equivalent result, but no complications which are in the operative group. Open surgical approach does reduce the risk of re-rupture. We normally do a dynamic ultrasound if and it has been indicated by Lawrence et al. If the dynamic ultrasound shows a gap of more than 10 mm in which the deficit of plantar flexion strength increases significantly. It has been also shown that Vacapad boots are better than wedges as the plantar flexion is at the ankle joint and not the midfoot joint. I will advise the patient to wear the boot while sleeping, and he can remove the boot while taking shower, but has to be on the tiptoe. Regarding the operative incision, posteromedial incision is given. Sural nerve is posterolateral, crosses the midline at 10 cm above calcaneal insertions. I will do a Krakow or a Kessler sort of repair with number 2, and the vertical circumferential repair with 2-0. I will also repair the peritoneum with 2-0. There is no indication for non-weight bearing after the operative intervention, and there is no difference. Current practice is to do percutaneous repairs with various available kits like Echelon and PARS. If a chronic rupture happens, we can have different options. If less than 3 cm is the gap, we can do a direct repair. if there is 3 to 5 centimeter of gap, we can do a gastrocnemius VY advancement plasty, and if there is more than 5 centimeter of the gap, we can do FHL graft. We release the FHL from proximal to the knot of Henry and transfer it through the calcaneus. The gastrocnemius turn down procedure of VY advanced plasty is done at the apex at the musculotendinous junction. The incision goes through only the superficial part of the tendon itself.